Hi everyone, welcome to the BRC Early Career Researcher Showcase talk. It's great to have you all here. Thanks for joining us today. First up, we will introduce Carol Cunningham, who is a part MS Musculoskeletal and Dermatology Clinical Research Fellow. So yeah, here's Carol, enjoy.
Good afternoon. Hi, I'm a BRC Clinical Research Fellow in Photomedicine, undertaking research across dermatology and musculoskeletal themes of photosensitivity and connective tissue diseases. My research is funded by the Biomedical Research Council. We know that photosensitivity is a well-recognized, frequently disabling feature of lupus and dermatomyositis to prototypical connective tissue diseases. It is one of the diagnostic classification criteria of systemic lupus erythematosus. However, very little is known of other connective tissue diseases within the connective tissue disease spectrum. It's not difficult to appreciate the intense inflammation present in this patient. You can see the photodistributed eruption on the dorsal left hand and a vesiculobullous eruption on the left posterior shoulder following sunlight exposure, later confirmed on phototesting to be induced by UVA radiation. The Lupus Extended Autoimmune Phenotype Study is a longitudinal cohort study. It's a collaboration between dermatology and rheumatology, and it seeks to characterize connective tissue disease based on the integration and correlation of immunogenetic, serologic, and clinical features, including photosensitivity, which is the focus of this talk. The aim of the LEAP study is to move away from the existing traditional classification criteria and towards a more mechanistic molecular taxonomy based on patients' endotypes. This is an inclusive study, and therefore patients were recruited if they had any recognized connective tissue disease feature and a positive ANA and/or ENA. Rheumatologist diagnosis was used as the primary classifier. Participants were assigned to one of the 6 following groups by a rheumatologist. These are well characterized diagnostic groups within the connective tissue disease spectrum. For over 300 participants, and patients were well characterized along phenotypic, serologic, and immunogenetic themes. As I said before, photosensitivity is well described in SLE and dermatomyositis. However, the prevalence of photosensitivity is unknown in other connective tissue disease subtypes. The photosensitivity study, therefore, seeks to clarify, investigate, and characterize photosensitivity within these groups, and is comprised of 2 components, a sunlight sensitivity questionnaire and a mechanistic study. We will focus on the questionnaire component to date. The mechanistic study is something that we plan in the future and has not yet been undertaken. Objectives of the sunlight sensitivity questionnaire were to determine patients' phototypes based on modified Fitzpatrick classification, to screen for sunlight-related skin reactions, i.e. photosensitivity, and to characterize photosensitivity by asking qualifier questions. We then sought to analyze this data and integrate it with the existing main LEAP database. It was an 18-component questionnaire, which is basically an adaptation of a previously validated tool, and we recruited 293 of 300 LEAP participants. Questionnaire responses were collated and data was extracted and analysed. The next stage following this will be to corroborate patients' responses via questionnaire responses via patient interview. We dichotomized patients into those who considered themselves to be sunlight sensitive and those who did not. And subjectively photosensitive patients progressed to completing the qualifier questions 1 to 16. Of the 293 patients who were invited to participate, 185 responded and completed the questionnaire. There were 108 non-respondents. Ages range from 25 to 74 with a median age of 53. And as you would expect in a connective tissue disease cohort, the gender was predominantly female. There was an overwhelming representation, a Caucasian representation within this cohort, with representation across other ethnic minorities also. All skin phototypes were represented, however, skin phototype 3 was the most common. Similarly, across all CTGs across the entire spectrum were represented, and most cases were actually of SLE. However, the other CTD diagnostic subtypes were also represented: undifferentiated connective tissue disease, primary Sjogren's syndrome, systemic sclerosis, mixed connective tissue disease, and inflammatory myositis. We found that 57% of all patients were photosensitive across all connective tissue disease subtypes, and 39% were not. 3% simply didn't know, and 1% left that section blank. Of those who were photosensitive, that's 105, 70% described associated systemic symptoms. Most of these described tiredness, joint pain, influenza symptoms, or other systemic symptoms such as headache. We've hypothesized that it is likely that these symptoms are driven by the interferon pathway, which we know underlies connective tissue diseases such as SLE and dermatomyositis. Importantly, it's important to note the impact of this on their quality of life, with a large number of photosensitive patients reporting impairment of quality of life scores is greater than 5 out of 10. Where a score of 0 is not affected and 10 is extremely affected. As you can see, there's a substantial prevalence of photosensitivity across the entire CTD spectrum. This is unprecedented and previously unreported in primary Sjogren's syndrome, undifferentiated connective tissue disease, mixed connective tissue disease / overlap, and systemic sclerosis. As I mentioned before, it has already been established in patients with SLE and inflammatory myositis. I previously made reference to the interferon pathway as being a significant driver in the underlying immune pathogenesis of a range of connective tissue diseases, but predominantly systemic lupus. And we know that interferon levels rise post UVB irradiation, which induces apoptosis within the skin. Interferon signaling gene scores can be used as an indicator of interferon activity, and these levels have been measured in a subset by my colleagues Tracy Briggs and John Reynolds. And we looked to integrate the ISG data that was available on a subset of these patients with our photosensitivity data. However, we didn't find a significant correlation between ISG score and photosensitivity. We know now that there's a substantial prevalence of self-reported photosensitivity across the entire connective tissue disease spectrum, not limited simply to the prototypical inflammatory myositis and systemic lupus erythematosus, which are well described and there's extensive research published on those. Associated systemic symptoms were seen in most photosensitive patients, which really impaired their quality of life. As I said, there's no evidence of a clear relationship between self-reported photosensitivity and overall serum ISG score. However, only a limited selection of ISGs were analysed. But we know that photosensitivity is an important feature across the entire CTD spectrum, and further exploration of this heterogeneous group is warranted to identify shared mechanisms underlying these photosensitive endotypes. Following corroboration of questionnaire responses via interview, we will correlate these data with specific antibody expression and tissue sampling of photo-provoked skin for RNA or a nanostring analysis once this is feasible. This has not been possible due to the COVID crisis. We hope to identify future candidate molecules for targeted individualized treatment and thus improve the quality of life for these patients. Thanks to the BRC and to my research supervisors.
Brilliant, thanks so much, Carol. Next up we have Hearing Health PhD Celia Hulme. Thanks very much.
Great stuff. I'm just making sure that everybody could see that. Just before I start, I just wanted to let you know that I am a sign language user. So the voice that you can hear is that of my interpreter. Okay, so I'm going to be talking about the lived experiences of British Sign Language who access NHS hearing aid services. So there's 87,000 deaf British Sign Language users living in the UK. Some of those wear hearing aids and access hearing aid clinics. They're not your typical users of hearing aid services, so therefore they're an underrepresented group. There's a lack of evidence from their experience and their perspectives amongst literature. So this study aims to ascertain their experiences of accessing hearing aid services and also wearing hearing aids. So I'm just going to briefly talk about the methodology. So the approach design was underpinned by Interpretative Phenomenological Analysis, IPA for short. Sampling was purposive expert sampling, where researcher used own expert informants. Inclusion criteria, so participants needed to be over 18, wear hearing aids, live in England, use British Sign Language and access hearing aid services. Exclusion criteria was if you don't wear hearing aids, you live outside of England, under the age of 18, use sign language and wear cochlear implant. So the design of the study is a qualitative, semi-structured interview conducted in British Sign Language by a deaf researcher. So overall, there was 8 participants recruited, culturally deaf participants, 4 men and 4 females from the ages of 30 to 76. And the interviews were translated from sign language into English, and then I followed the 6-step IPA process for analysis. There we go, so the results. So I identified 4 main themes, overarching themes, and within those 4 themes there are 3 sub-themes within that. So it's hearing and deaf literacy. So when we're talking about literacy here, we're actually not meaning reading and writing. What I'm referring to is the understanding of other people's worldview, and in this situation from a deaf and hearing perspective. So the first element here is identity. So what participants reported was, and what's been identified, is they have a very strong deaf identity within the deaf community. So when they attend clinics, that identity disappears. They're not seen as a deaf person. They are seen as a person that's signed. So when they're in clinic, they have the confusion on where they find themselves and where they can place themselves within their setting. So the second element here is awareness and ownership of hearing. And this was a really difficult part of the interviews, because you're asking a particular population what it's like to hear and why they use their hearing aids. It's a very unnatural topic to discuss within the deaf community. If you don't talk about what it is to hear, it's not a natural way of communicating how their deafness. They don't feel that that word applies to them as deaf people. So that was quite an interesting finding. So the third element here is responsibility. Very few described agency, self-advocacy, and also patient activation tactics. And they had very little knowledge of what their hearing aids could actually achieve. Okay, so this is the second theme that was identified, and this is who knows best. And this explored the contrast between culture and medicine. So the first element here is expert by experience. So these are individuals that wear hearing aids every day and have done for all their lives. So when they attend an audiology clinic, they don't feel that that's recognised by the professionals. They're made to feel small and that they're the problem, and the experts know better, and that's how they're perceived through attitude. Second element under this theme is they're seeing the ear and not the person. So all 8 participants reported that audiology are not supplying a person-centered approach. So they're there to look at the ear or the technology, but they're not looking at that holistically. And it's not about the individual. Making informed choices. All reported that this was difficult. Audiologists don't ask what they use the hearing aid for, or even with and without interpreter, they don't find out their lifestyle choices. They're just giving a set of hearing aids with very little information. So this is the third theme, hearing aids and what they're used for. So this looks at the motivation behind the use of hearing aids. So those that may have rejected a hearing aid and then returned back, and why they wear hearing aids. So the first one is why reject hearing aids and then come back to them. So 3 out of 8 participants rejected hearing aids and returned later on in life. They generally rejected hearing aids after school age, so because of peer pressure, negative educational experiences, they didn't find them useful. They're in signing environments at home and also further education. 2 of the participants returned 15 to 17 years later because they wanted to be able to hear their baby cry. The third one was because of medical reasons. Sorry, the second one was medical reasons. And the third participant came back 55 years later because of improvements in technology. So I asked why they wear hearing aids, and they all reported that they wanted to feel safe and comfortable and have access to environmental sounds. Understanding hearing aids, the third element. And this was really interesting because you could see diversity within generation. So the younger generation were really motivated by what hearing aids could offer, and they could connect to Bluetooth and television and all those exciting things. And then 40 to 60-year-olds didn't know that they could access all these new advancements. And then over 60, they just wanted to turn the hearing aid on and off, and they were really happy with having that access. So this is the final theme, and it's always the same. So participants reported their view on the services have always been the same. Nothing's ever changed. So we've got inequality to access. So they described feeling disempowered, no autonomy. So for example, barriers to making appointments. So you arrive, nobody signs. The onus is on the deaf person to facilitate communication between professionals. Also, the lack of cultural competency at all levels, so structural, organisational, professional and practitioner level. So for example, there's nobody that's able to sign, lack of deaf awareness. The waiting room isn't designed with deaf British Sign Language users in mind. No, little information is accessible in British Sign Language. So systemic discrimination, so everything is hearing centred. So for example, it's all sound-based, telephone booking system, patient feedback, speech is the main source of communication. So it's a one-size-fits-all approach for many of the audiology services. Okay, so I've got 3 final take-home messages. So the first one is the word hearing, and the concept of to hear isn't natural within the deaf sign language population, so it has implications on their identity. So there's literature out there on deaf identity, but it doesn't explore how people feel about hearing and how that applies to the deaf community, so more research is needed here. The second is it's assumed that the primary use of wearing hearing aid is for language communication access. This isn't the case with this signing population. So it means that actually audiologists have access to this information, and they now know the motives behind wearing hearing aids for this population. The third is the results show audiology is failing in terms of cultural competency for deaf sign language users, so they need to review their current practices. And I would like to take this opportunity to acknowledge NIHR for their funding for the project, and all my supervisors for their support and guidance. So we've got Professor Ailish Young, and we've got Professor Kevin Monroe, and lastly we've got Dr. Catherine Rogers. Thank you.
Hi, that was a fantastic presentation. I've really enjoyed listening to both Carol and Celia. I think there's some questions coming through on the chat, and I think this might be an opportune moment for others. If you have questions for both Carol and Celia, please put them forward. But I'm just going to ask some that Kevin has put in the chat, and I had a couple too. So this is the first one is for Celia. Sorry. Do you think aspects of your PhD could generalize to other cultural groups?
Yes, most definitely. I think it impacts and influences other cultural groups, so BAME groups, underrepresented groups. I can definitely see it can be generalised, definitely, and applied to other minority groups. Yeah. And I think sorry, just to go on from there, I think what surprised me, particularly with the hearing theme, is myself. I'm an assertive deaf person, both within the deaf community, and I can mix with hearing community, but I think I was taken aback when I started to think about what does that word hearing mean to me. I've never applied it to myself and my lived experience, and that came out in the interviews very strongly. I think it's partly, I wasn't surprised, and there was lots of things that were quite shocking within the findings, but some things I expected, and then other things were a surprise. And I think the next steps going forward is to find out more from audiology and their perspective and audiologists' perspective, and then sort of develop a plan as to how to improve access for deaf people and deaf sign language users who attend these clinics. So maybe it's work in practice, policies, training, those types of things. So this, I think this study in particular will have big impact. It's the first study at the moment, so going forward it's going to have, and it's the first study of its kind from a deaf perspective as well. So it's exciting. I'm looking forward going forward.
Very exciting, and it was interesting. I think I was interested to know how you could use your findings to provide interventions that would improve the experience for going to clinic, etc. So I think you've answered that really well. There's another question here around asking your opinion on how consultations in the NHS can be improved in this current COVID world. Is it through face-to-face consultations or digital consultations? It's in the chat, Celia.
Yeah, I'm just going to read the question. Okay, so I have no experience of receiving a consultation with a mask on. I have heard other people having to attend clinics where people are wearing masks and they're covering up their face. So I know people have wear the facial cover and also the mask. So I think people have had different experiences in terms of how they've managed to access communication under the current circumstances. I know with deaf people, I know they prefer face-to-face consultations rather than online. But I think there's definitely more research needed because it's new for everybody. So we're all adjusting to new climate. So I think we're just navigating through different experiences and going and learning along the way what's the right way and what's more difficult. And I think it's through those experiences we'll start to develop some firm ways of working that works.
That's fantastic. And I think Jane has said here that it would be great to kind of do a BRC training session on how to improve consultation. So how can we work in some of the training opportunities, and if we could work together on that, which I think is a very good idea, Jane. So I'm conscious of time and we've got other people to hear. So we can move on to hear the next presentation. I guess, Jane, are you sharing the slides?
No, it should be Sarah next. She'll share the screen.
So it's with great pleasure that Sarah's going to speak next on DiagNOSEis, and that's exploring early detection of lung cancer with nasosorption. So I shall be interested to hear about this.
Okay, hopefully you can all hear me and see my slides. Yeah, so my PhD project is looking into early detection of lung cancer, and nasosorption is a sampling technique in the nose, but I'll go through why we're looking at the nose a bit later. So first, really, it's why we're even thinking about early detection of lung cancer. So lung cancer is the leading cause of cancer-related death worldwide and in the UK. And has a really low survival rate, so about 5%, 10-year survival. And despite significant improvement in treatments, or a significant investment in treatment, we've only seen about a 2% increase in the survival rate in 40 years, which is much lower than we see with other cancer types. So there's something that we're not quite doing right in lung cancer. But actually, the majority of lung cancers are diagnosed quite late, once the cancer spread past the lungs and metastasized. And actually, we estimate that we could achieve a 33% increase in overall survival just by detecting these lung cancers earlier at stage 1 or perhaps 2, but once they're still within the lung and not spread to the rest of the body. But lung cancer has quite generic symptoms, things like a cough, shortness of breath, that tend to overlap with the risk factors for lung cancer, which are things like chronic obstructive pulmonary disorder or COPD and smoking. So the best way to do this is going to be via screening the at-risk population. The current screening is focused on low-dose computed tomography, or LDCT, which is just a scan of the lungs that identifies nodules, and it's the current gold standard for screening and has been implemented in the US. But actually there are some disadvantages to this technique, which include it's quite expensive, it requires specialist teams and a patient coming to a dedicated centre, and for the patients who are most at risk, for those in lower socioeconomic groups, they're quite reluctant to engage with this kind of screening. And also it requires a radiation dose. So it's been estimated that for every 22 lung cancer deaths prevented, 1 would be caused by the exposure to radiation. So ideally we wouldn't be screening too many people with this technique. And the alternative is biomarkers. So biomarkers are molecules that we can identify in peripheral fluids or biological fluids that indicate a disease's presence, such as lung cancer. And most biomarkers are kind of focused on those in blood because it's easy to access. But we think that all the biomarkers so far that have been identified in blood haven't made it to the clinic. And maybe looking in the blood is the wrong place to go. Instead, maybe we should be looking at something that's more relevant to the lungs. and closer to the site of injury, i.e. the lung cancer. So we're actually looking in the nose. The theory behind markers in the nose is twofold. So coughing and exhalation, especially in patients at risk of lung cancer, they're more likely to be coughing anyway, might bring markers from your lungs to the back of your nose where we can sample them. But also the nasal epithelium, which is the cells that coat your nose, are quite similar to the bronchial epithelium, so the cells coating your lungs. And both are exposed to similar risk factors, so both would be exposed to smoke if you were a smoker. And there's some suggestion that the nose is involved in chronic obstructive pulmonary disorder. It's part of the field of injury. And so maybe the markers that would be produced in the lower respiratory tract that indicate presence of lung cancer might also be expressed in the nose. So the sampling technique we're using is nasosorption. It's much less invasive than blood sampling, doesn't require a needle. It's also less invasive than other nasal sampling techniques, such as nasopharyngeal swabbing, as many of you might have experienced by now. This is just a really small, soft swab. It doesn't go past the kind of top of your nose. It's there for a minute and you take it out and then we process it. It's also better than some other nasal sampling techniques like nasal lavage because we can control the dilution. And it's been used successfully for diseases such as asthma, respiratory viral infections such as RSV. And also people have managed to distinguish between benign and cancerous lesions in the lung by using RNA taken from the nose. And we're also exploring it for COVID, which is another topic that I don't have time to go into today. So the samples that we've got for the lung cancer studies are from this Manchester lung health check that happened in 2017. And the aims were just to determine whether it was feasible and effective to screen the population of Manchester for lung cancer, and whether we could improve engagement of lower socioeconomic groups by taking the CT scanners to supermarket car parks rather than have patients having to come into hospital. And that was quite successful. But we have just over 700 samples, nasal samples from patients from this study, all of which have a greater than 1.5% 6-year risk of lung cancer. And on top of having some patients that are positive for lung cancer that we can use to develop biomarkers, we also have a mix of current and ex-smokers and patients with and without COPD, which gives us scope to kind of look at not just lung cancer and not lung cancer, but also the risk factors for lung cancer, and maybe start to stratify patients based on risk using nasal samples as well. So actually the first set of samples that I submitted didn't have any lung cancer patients in at all, partly because we were analysing this with mass spectrometry, which we were looking at proteins, and this was a technique that hadn't been used with nasosorption before. And our lung cancer positive samples are quite precious, not very many of them. Many patients had lung cancer in these screening studies, which is good, but restricts the number of samples that we have. So I didn't want to waste them if the technique wouldn't work. We were also interested in just characterising the nasal proteome, so the proteins that we find in your nose, because again, that's not really been done before, and kind of characterise our at-risk population. And then also look into, are there differences between patients with and without COPD, or between current and ex-smokers, and start to kind of characterise these measures of risk in lung cancer, patients at risk of lung cancer. So the preliminary results from this study were quite exciting. So we're identifying about 2,000 proteins on these nasal strips, which is quite exciting and more than I expected. They're kind of a mix of things like matrix-related proteins, so mucin, so the stuff that kind of gunk in your nose, keratins, so things from like the epithelial layer from the, I guess, like would be on your skin, and also immune-related proteins such as complement. We also saw a wide range of proteins that are different between patients with COPD and no COPD, as you can see in the volcano plot on the left, which is quite exciting. It means that we're seeing some differences in COPD in these nasal samples. We also saw some differences between current and ex-smokers, although less than in COPD versus none. And I'm thinking that's partly because we're not just looking at smoking versus not smoking, we're just looking at patients who have stopped smoking versus those that are still. And although a lot of changes that happen when you smoke do disappear over time when you stop smoking, some of them would still remain. So perhaps these patients just aren't as distinct from each other as they would with COPD and not COPD. But in general, this indicates that this technique has got potential for lung diseases, and I'm in the process of analysing the lung cancer positive samples. So hopefully we'll have some more interesting data to come. Yeah. But thank you for listening. Just want to acknowledge my supervisors, the BioMS facility in the University of Manchester have been a great help with analysing these samples. Phil Crosby is always there to answer my questions about the samples that we've got, and my lab for helping out. So thank you.
Sorry, thank you very much. That was a particularly interesting talk. I can see that there are a couple of questions just coming through the chat. So is there any data on the sensitivity and specificity of nasosorption for lung cancer in screening for lung cancer, which is a question from Carol?
So actually not at the moment. So I think this is possibly the first time that people have been using the nose for lung cancer. I haven't found any other literature for lung cancer screening. The study that showed the difference between benign and cancerous lesions was based on RNA rather than proteins, and also was just looking at patients that had lesions and trying to distinguish between them. It's also quite hard to get information out of that study because it was a commercial one done in the US. So although they've published the data, it's actually quite hard to interrogate exactly the specificity and sensitivity of those tests because they're now commercially available and you can buy them. So they've not really told you what the markers are, and they're telling you it's good, but they're not being forthcoming with the data, if that makes sense. So this, what I'm doing is really preliminary, just to see whether it's even possible to do this. And I think sensitivity and specificity will come later once we need to collect more samples for that and have specific biomarkers that we're particularly interested in. This is more, at the moment, it's just a look-see to see whether it's a viable technique to use.
And I guess Paul's follow-on question is, have you been able to sample normal people, so for example non-COPD or non-smokers or non-lung cancer people? Is that something that you've been able to do? So
we have, within the data set we do have non-COPD ex-smokers, but to be within this greater than 1.5% risk, you would need to have some smoking history, and we don't currently have ethics to take healthy samples. So I'm in the process of applying for ethics, which was happening pre-COVID. It's much more difficult now when you're taking a nasal sample is not as easy as it would have been during the COVID pandemic. So I think at the moment that's kind of been put on the back burner. It would be a great, I would have loved to have that data set, but I'm just not sure it's going to be possible during this project. I initially did look at some healthy samples, but I've just been using them for workup. I couldn't analyze them. Yeah, we don't have ethics for that. Yeah, it would be great. I'd love to, but it's just a case of getting ethics and doing that, taking nasal samples during a COVID pandemic, which is a bit of an issue.
And I think we've got one final one from Kim. And do you think the extent of smoking history may affect the quality of the results in terms of the extent of damage to the epithelium?
Actually, that's a really good question. Yeah, potentially. I think, especially because some of these patients have, their smoking history is quite extensive. I think a few of them have 180 pack years worth of smoking history, which is huge. It's not something that I'd be able to kind of look at in the patients that we sampled specifically because we don't have that data, but it would be interesting to, I guess, to look in the literature and see whether the extent of damage would be permanent. Yeah, it is possible, but I guess also the markers that are produced during that damage, maybe more like increased shedding of the epithelial layer, would lead to kind of increased keratins and intracellular components in the samples that we're taking. And we are seeing that in COPD anyway, I'm seeing an increase in keratins, and that might just be an indication that there's a higher turnover in the epithelial layer. So I guess it is possible that it might affect my samples, but potentially it is also an indicator of damage and therefore an indicator of risk. Seeing an increased amount of keratin and increased intracellular components. But it's definitely something to bear in mind. Yeah.
Okay, thank you very much, Sarah. That was another fantastic talk. So next on the agenda is Sian Bladon, and she'll be speaking about exploring the antimicrobial burden of sepsis patients admitted to intensive care using EHR, so electronic health records. Over to you, Sian.
Hi, so I hope you can all see my screen. So yeah, I'm a final year PhD student. I'm based in the Centre for Health Informatics. So today I'm just going to be talking about a study that I've been doing exploring the antimicrobial burden of sepsis in ICU patients. So for a bit of background, sepsis is defined as life-threatening organ dysfunction caused by a dysregulated host response to infection. Estimates vary, but the WHO have recently reported that in 2017 it was thought to be related to approximately 11 million deaths globally, so it's quite a significant issue. Symptoms vary a lot between patients, so this sort of depends on which organs have been affected. So it can be increased respiration rate, heart rate, or reduced kidney function and liver function. But the way that it varies so much between patients makes it quite difficult to spot clinically. So there have been recent campaigns to raise awareness of sepsis among clinicians and the public. So management of sepsis consists of antimicrobials to treat the underlying cause of infection and other measures to support dysfunctioning organs. However, because of the problem with increased resistance to antimicrobials around the world, this means that infections are becoming harder to treat and more people are at risk of developing sepsis and dying. One of the main drivers behind the increase in antibiotic resistance is overuse of antibiotics, so there's a need to reduce overall consumption of antibiotics, but this has to be balanced with a need to treat patients suspected of sepsis promptly. So there have been some studies looking at the timing of treatment that have looked at these to see whether delays in beginning antibiotic treatment for sepsis is associated with worse outcomes. There have also been some other studies looking at comparing short and long duration of antibiotic courses, but most of these have been sort of smaller scale randomised control trial studies, and so the results are quite mixed coming out of those. So the aims of my study were to use a large cohort selected from electronic health record data to explore the antimicrobial burden of sepsis patients in an ICU and to look at the association between the use of antimicrobials and mortality. So the data that I used came from the MIMIC3 database, which is a free open access database of anonymised patient records from a single hospital in the US. That goes from 2001 to 2012. So it's a very comprehensive database that has 26 tables containing all kinds of data about the hospital stay, so microbiology tests, any procedures, caregivers, and as well as physiological measurements. So the data that I was focusing on was from the prescriptions table and the input events table. So the prescriptions is any prescription from the entire hospital admission. The downside of the prescriptions table is that you don't know how frequently doses were administered. Whereas the input events does detail individual IV administrations of drugs given to patients in the ICU, but it only covers the ICU admission, not the entire hospital admission. So I've identified patients over the age of 16 with incident sepsis admitted to the ICU between 2008 and 2012. And the reason that I've narrowed down that the time rather than using the full database is because there was a switch in the EHR system used by the hospital. So the prescriptions and the IV data wasn't captured before 2008. So one of the challenges with sepsis research is the different criteria that you can use to identify patients. So I've used a few different criteria. So the main criteria that I used was whether they met the Sepsis 3 definition for sepsis, which is a sequential organ failure assessment or SOFA score greater than or equal to 2 and suspicion of infection. So these were identified using the physiological measurements recorded in their medical records. So then the other subgroups of this cohort were based on ICD codes, which are diagnostic codes that are usually done at the end of a hospital admission. So there are explicit ICD codes for sepsis and severe sepsis, but these are not commonly used. So the Angus criteria and the Martin criteria are combinations of codes for organ dysfunction and systemic infection, which are thought to also capture sepsis patients. So for analysis, I've looked at the overall use of antimicrobials for the whole cohort, and have also summarised individual antimicrobial exposure in 3 different ways. So I've looked at, oh, that's not coming up. Sorry, just give me a second. So the number of courses, the total exposure days, and the cumulative exposure days. So just to illustrate that with an example, if each of these orange lines is a prescription, so that this patient has received 4 courses over a total of 7 days, but to calculate the cumulative exposure, where they've been prescribed more than 1 antimicrobial on the same day, that day has counted twice. And then I've also looked at survival of patients using Kaplan-Meier curves and a Cox proportional hazards regression model. So of the just under 24,000 ICU stays that were available in that time period in the database, there were just under 37% met the sepsis 3 criteria. So the size of the cohort decreases depending on which codes you use to look for patients. So only 18% of those patients had an explicit code in their medical record for sepsis. And this table just shows some of the basic demographics. So you can see that as the size of the cohort decreases, the age increases slightly, as does the SOFA score, which was the level of organ dysfunction, and the Elixhauser comorbidity index, which is a measure of comorbidities that are pre-existing conditions that the patients have. So those both increase as the cohort size decreases. So there were over 32,000 prescriptions for these patients in the ICU and for their hospital admission. And so antibiotics accounted for 94% of these prescriptions. The graph on the left is just showing the breakdown by type. So you can see that antivirals were accounted for just under 2% of prescriptions, and antifungal medication was used for just under 4%. So the graph on the right hand side is showing the top 10 most frequently used antibiotics. So vancomycin accounted for just under 23% of all of the prescriptions. So vancomycin is quite commonly used to treat MRSA, so the hospital-acquired infection. So most of the antibiotics were administered via IV. I think most of the rest of the ones were enteral. The median length of prescriptions was 3 days, and on average, each patient received 3 different antimicrobials. So looking at the individual exposure, so this table is showing the whole cohort and the subgroups and the 3 different measures of antibiotic exposure. So you can see that the number of courses, the average number of courses does increase as the cohort size decreases. So the patients with an explicit code for sepsis received more antimicrobials, and also were exposed on more days, which if they had higher levels of organ dysfunction would make sense if they're suffering from more severe disease. So to look at that in a bit more detail, to look at how the exposure changes, looking at compared to a few of the other characteristics. So this is looking at age. So the graphs on the bottom show the distribution of the number of courses and the exposure days across all of the different age groups. For the table, I've just picked out the lowest and the middle and the highest age group to just compare. So you can see that the number of courses doesn't change in the older patients. but you can see, looking at the exposure days, that they are exposed on a fewer number of days, which might be because they're older, they're at a higher risk of death anyway, so they're less likely to be exposed to antibiotics because they're at greater risk of dying, which I'll come back to. So this is a similar thing, looking at the SOFA score, so the level of organ dysfunction. So you can see that patients with a higher SOFA score are exposed to an average of 4 different antimicrobials compared to 3 in the lowest SOFA group. A slightly strange pattern in the exposure days, in that the sort of peaks in the middle for the patients in the middle SOFA group, and with the patients with the highest SOFA group only receiving an average 4 days worth of antibiotics. But again, similar to the age, this could be because they're at a higher risk of death. So they sort of die before they receive more antimicrobials, if that makes sense. And again, this is just showing it for the comorbidity index. So this shows that patients with a higher level of comorbidities are receiving higher numbers of antimicrobials on more days. So to look at mortality, as you would expect with the smaller cohorts having higher levels of organ dysfunction and comorbidities, they do also see higher levels of mortality, and this is when including ICU, hospital and 30-day mortality. So these are survival curves showing 30-day mortality. So the lower lines show worse survival. So the red line here is the whole cohort, and then you've got the orange line is the Angus criteria, then the Martin criteria, and the bottom line is the explicit ICD code criteria. So they've got the worst survival over 30 days. And this is just showing a similar thing for age on the left, SOFA score in the middle, and comorbidity index on the right. So the red lines with the better survival correspond to the younger patients with lower levels of organ dysfunction and lower levels of comorbidity, whereas the orange lines at the bottom are the older patients with higher levels of organ dysfunction and higher levels of comorbidity. So in order to look at this in a bit more detail, used Cox proportional hazards regression to look at the factors associated with mortality. So because of the issue that I mentioned with the older patients and the patients with the higher SOFA score being more likely to die early on in their ICU stay, so less likely to receive more antimicrobials. The antimicrobial exposure variables, the two at the bottom, were included in the model as time varying covariates. So I won't go this into too much detail, but the hazard ratios show which factors are associated with mortality. So anything above 1 is an increased association with mortality. So the results from this show that age and the comorbidities are not significantly associated with mortality, because those they're very close to 1. The hazard ratio for the SOFA score and the number of antimicrobials prescribed show that an increase in those numbers is associated with decreased survival. But the hazard ratio for the number of exposure days is less than 1. So that means that an increased number of exposure days is associated with increased survival. So to summarise, depending on the selection criteria, the subcohorts vary in size and severity of disease, which has been looked at in other studies before and is a sort of common problem in sepsis research. So using the codes to identify patients is thought to underestimate sepsis, but using the sepsis 3 criteria is thought to overestimate it. So sepsis patients on average receive 3 different courses of antimicrobials and are exposed for an average of 5 days. antimicrobial use does vary in relation to patients' levels of disease severity and comorbidities. The Cox regression showed that a higher SOFA score and number of antimicrobials prescribed was associated with higher mortality, but a higher number of exposure days was associated with lower mortality. So thank you. And I'm sorry, I think I went over then.
Thank you, Sian. That was a fantastic talk. And there's a couple of questions that have come up in the chat, and actually a question I had myself, which was, why did you use the US data, and particularly the time frame that you did? And do you think that you could use this type of work on a UK population, and what that might be?
Yes, the reason that I used the US data was because it is free and open access, so it was very easy to get access to it in compared to a lot of UK data, and also because of the volume of the data available. It's much more, it's very, very in-depth and very comprehensive data set.
But do you think, I mean, what would be the differences between the US and UK populations in terms of like access to care or demographics? You know, is what you've done here transferable across to the UK, and what may be the differences?
That's a very good question, and not something that I've looked at really. 'Cause, yeah, you would expect care to differ between different countries, but you'd also expect different sort of clinical practices in the way that different things are treated, and the way that antimicrobials are used would probably vary quite a lot. So that's something that we need to look into.
And David has one final question, is, do you have a means of censoring patients who died for stats, as it looks like an artifactual finding related to early death related to antibiotic exposure? It's in the chat, so if I haven't read it out quite the right way.
So by including the exposure variables in the Cox model as time varying covariates, that should have reduced any sort of impact from this. I think they call it like an immortal time bias. So that has been taken into account with that Cox model. Okay.
And I think one final question is, Dan's asking, does the UK ICNARC data set incorporate antimicrobial use? Do you know that, and is that a possible thing to use?
I'm not sure is the answer to that. Oh, Paul says ICNARC does not. So no, it does not.
Okay.
I am, in the next part of my project, I am going on to use data from UK. So I'll be using a combination of primary and secondary care data from the UK.
Yeah, and there's another question, one final question, or in the chat from David.
So yeah, so there was a lot of vancomycin used. It might be that they do have a specific problem in that hospital. I did find another US study that had similar rates in a different hospital, so it might be that they treat sort of less conservatively than we might do here. So even if a patient is just suspected of having MRSA, they might just treat them with vancomycin as a precaution.
Okay. Thank you very much, Sian. That was a really good talk.
I'm sorry for going over. I never
know.
No,
okay. But thank you. So next up is Mikey Lebrett, and a snapshot of lung cancer screening selection in Manchester.
Thank you very much. Thank you. Hi everyone, I'm Mikey. I'm a final year PhD student. And I'm going to just give a quick summary of a paper we recently published, which looks at lung cancer screening selection in Manchester. And I'm very pleased that Sarah presented first, because it means I can skip through a lot of the intro stuff about lung cancer and get straight to it. So first of all, as Sarah mentioned, lung cancer is really common. It's the biggest cause of cancer death in the UK. It's the most common cause of cancer worldwide. And it's also got really, really poor survival statistics. So someone who's diagnosed with lung cancer can expect a 40% chance of survival 1 year, and that drops significantly down to 16% over 5 years and 10% over 10 years. Over the past decade, there have been 2 major studies which have shown that low-dose CT screening reduces lung cancer-specific mortality. So what that means is, if you, these were randomized controlled trials. The first one was the National Lung Screening Trial in the USA, and that showed a 20% reduction in lung cancer-related death in the screening arm versus the control group, which was just a chest X-ray, which has been proven to not be helpful for lung cancer screening. And the second one, which was recently published last year, is the European counterpart to this, which was the Nelson study, which also showed a significant reduction in lung cancer death due to screening. An important challenge in lung cancer screening is that you need to figure out who should be screened. If you want to have a successful screening program, you want to be aiming, targeting your screening to those who are most at risk of lung cancer, in order to ensure that you're not screening a population who aren't likely to get the disease, which is going to make it an expensive, ineffective screening program and also expose a lot of people to unnecessary harms. So there's 2 methods really of approaching screening selection. The first one is using generalized eligibility criteria. So this is similar to what that large screening trial did. You pick an age bracket, for example, 55 to 74, and you pick I think that should be actually 30 pack year smoking history. You pick a history of smoke exposure, and you just screen everyone who fits into that category. And the issue, the potential issue with this is that you have a large range of risk, of people at a large range of different risks in your screening population. And therefore that could theoretically reduce screening efficiency and increase the harm. And the alternative really is the individual risk prediction model for screening. And that takes a person's risk factors, all the various demographic and clinical factors that they have, and it produces a person's specific risk of developing lung cancer over a specific time frame. And this has been shown in a number of studies to select a higher risk screening cohort and therefore increase the efficiency and the efficacy of the screening program. And 2 of these models that we're going to discuss today, one is called the PLCO model, and that's got, you can see all the clinical factors included in that on the left there. And the other is the Liverpool Lung Project, the LLP model on the right, which uses some of the factors are the same, but some of them are different to the PLCO model. As Sarah mentioned, a very fertile ground for research samples is I'm using the same data set that she was using. That's the pilot, the Manchester Lung Health Check pilot study. And the study screened, it assessed 2,500 people for screening, and ended up 1,500 approximately were eligible for lung cancer screening based on a 6-year lung cancer risk threshold as assessed by that risk model I talked about, the PLCO risk model. And anyone who had a more than 1.5% chance of lung cancer in the next 6 years was offered screening. And at the end of the trial, there were 62 diagnoses of lung cancer after about 15 months. Which is a 4.3% detection rate, which is remarkably high for a trial of this type. And in addition to collecting the data that was needed to assess people by the PLCO model score, they also collected other data. So what I'm going to be presenting is an analysis of that data to show, had other selection criteria been used, what would this pilot have looked like? How many cancers would they have caught? How many people would have been screened? So without further ado, just going to jump straight into the results. So the first thing that we present in this paper is that was a considerable amount of variability in risk model performance. So you can see the 2 diagrams on the left here. The grey area is anyone who was screened using the PLCO threshold. And if you compare that with a theoretical method of the LLP risk model at a 2.5% risk of lung cancer over 5 years, you end up selecting a similar number of people for screening, However, in our cohort, that LLP risk model would have missed 7% of the cancers which were found in the trial. Now, it's really important to note that you would also have screened people who weren't screened in the trial under that model, and we can't account for what would have happened to those people, as it's a retrospective analysis. So it's a very tentative analysis, but interesting nonetheless. If you use the LLP 5% threshold, which was used in another UK lung screening trial, and is also being trialed prospectively in a couple of screening trials, you would have selected considerably fewer people for screening, but you would have missed over a quarter of the screen-detected lung cancers. So a really remarkable difference in the performance of the models. And if you compare it with the generalized eligibility criteria, that's sort of one-size-fits-all criteria, you would have selected 14% fewer participants for screening, and you would have missed 18% of screen-detected cancers. So it seems like it would have performed less well than the risk prediction models in this instance. The second thread that we follow through in this paper is looking at the PLCO risk model. What did it predict if we were to follow that through for the full 6 years? So after 15 months, we show that 87% of the 6-year predicted cancers were diagnosed already. And we did a number of projections based on the Nelson study incidence data. So pulling forward what we might see if the truck were to continue screening for the next 5 years. And we show that even if we use the most conservative projection, there would have been considerably more lung cancers found than was predicted by the risk model. If you take the least conservative projection, then it would be more than a 2.5 times amount of cancers after 6 years than were forecasted. So this really shows something about something about the risk model, or something about the risk model applied to a very, very high risk population in Manchester. And the final thing that we show is related to comorbidities. So we show that the higher your lung cancer risk is calculated, the more likely you are to have various other respiratory comorbidities, for example, airflow obstruction, the diagnosis of emphysema, or respiratory symptoms. And this is really important because one of the things that people might suggest looking at data from risk from screening trials is that if you just set the bar higher, then you end up catching a lot more cancers for a lot fewer screens. You end up having a very, very efficient program. The problem with this is that you also end up selecting a very, very ill, very old population for screening, which you might find a load of lung cancers, but it's not actually going to give you a huge amount of benefit to the population. So we show that with regards to airflow obstruction in this figure over here. And also airflow obstruction was borderline predictive of lung cancer diagnosis in this cohort, of actual diagnosis of lung cancer. There's other literature which shows that it is predictive. We couldn't show that significantly, but it's something indicative there. Finally, cardiovascular disease and coronary artery calcification, which is thinning of the coronary, which is clogging of the coronary artery, is also associated with lung cancer risk. So other measures of how ill someone is. And also the coronary artery calcification was independently predictive of lung cancer diagnosis, and that was significant, and there's also much less literature around about that. So that was quite an interesting finding. So very quickly, just to conclude, we showed that the methods of screening selection and the risk threshold used with your risk prediction models makes a real difference to the numbers screened and the cancers found. And again, we can't say which is best because it's a retrospective analysis, but it really highlights the need as the NHS is rolling out more and more lung cancer screening pilots across the country. There's a real need for prospective trials looking at what is the most effective risk model and what is the most effective risk threshold as well. So that's number one. Number two is that the risk model that we looked at and that was used may possibly underestimate risk in our population. And an important thing to point out is that the model was built in a non-screened population. So there's always an element when you screen a population of overdiagnosis and lead time bias, which needs to be taken into account. And again, it just shows the importance of more study before lung cancer screening is implemented widely across the country. We also show that the most at risk of lung cancer are also the most likely to be ill from other diseases. And this is quite unique because a lot of the previous research has been in randomized controlled trial populations related to this, and they have a lot of healthy volunteer bias. So we show in a real high-risk deprived population that there is a very, very strong association between comorbidity and lung cancer risk. We're doing, it was part of my PhD, we're also looking into life-gained risk models, where rather than just basing it on risk of lung cancer, you look at who's going to gain the most life from having a screening invitation. So that's an interesting direction to take the research into, to see whether that's effective at increasing the benefit of the screening program. And finally, we show that CAC and the airflow obstruction may be factors which could in the future potentially be integrated into risk models to improve risk prediction, possibly to inform how often someone is screened. So that's it, a bit of a whistle-stop tour. If anyone wants to see more details, they're invited to look at the paper. I'd like to thank my supervisors, all the co-authors for the paper, and obviously the BRC for funding my PhD. Thank you very, very much for listening.
That's great. Thanks so much, Mikey. Just a quick one. Could you kind of explain how you've worked with patients and public on your project, and how you communicated your results and any other information, and kind of what your plans are for the future as well?
That's a very good question. So for this particular project, it was quite technical and sort of stats-based and numbers-based. So this one was not necessarily the best example of sort of PPIE and getting people involved. Some of my other projects looking at risk perception, how people view their risks, have done a lot of work talking to actual people on the screening trucks and understanding how they view their risk of lung cancer. That's a separate talk for a different day. But yeah, very important.
Brilliant, thanks so much. Next up, we've got Stephanie Ling, who is a musculoskeletal PhD student. Thanks very much.
Okay, hi. So I'm a clinical research fellow working out of the Centre for Genetics and Genomics versus Arthritis, but my PhD is funded by the BRC, and I'm going to talk to you about it today. Thank you to anybody who is still here. So I'm interested in patients with rheumatoid arthritis. So this is a chronic autoinflammatory arthritis, and if you don't treat it quickly enough, it can lead to permanent joint damage and disability, as in the example here. But we don't want it to get to that stage. Two of the medications we can prescribe are anti-TNF alpha agents or biologics, and I'm interested in adalimumab and etanercept, and also their biosimilar versions, so it's like hula hoops and aldi hoops. So how do we maximise patient and cost benefit in this patient population? So we could make sure that people are receiving an appropriate dose of the drug, or we could also ensure that they're receiving the drug they're most likely to respond to first time, most likely a combination of both. RA does provide an opportunity for precision medicine, so that's the prescription of the right drug at the right dose in the right patient. But in RA, biologics are prescribed at set dosing intervals in pre-filled syringes, and up to 40% of patients don't respond to their first-line drug. So can we optimize the dosing of these medications? Previous work by a group has shown that drug levels are associated with response to biologics. So what that means is the higher your drug level, the more likely you are to achieve efficacy. So to summarize that, the orange arrows here are the standard dosing of adalimumab or Amgevita. So it's given at the same dose every 2 weeks. And what we want is for people to be in a nice green arc in the middle. However, some patients are underdosed and they are in this blue arc underneath. Perhaps they might benefit from having their doses closer together, perhaps only for a short time period. Similarly, there are patients who have achieved efficacy, but the drug levels are at too high a level and they're at risk of adverse events. And perhaps we could do with spacing these out. So I'm interested in whether it's possible to simulate a model with different dosing intervals. and I'm going to use a pharmacology modelling technique called population pharmacokinetic modelling to do this. So as part of the clinical trial arm of my PhD, it's a phase 0 clinical trial of patients on Amgevita and Benepali biosimilars. Step 1 is recruiting patients and collecting samples. Step 2 is then using the samples to obtain drug levels and generate a population pharmacokinetic model. And then step 3 will be simulating altering dosing intervals. I'm currently at this stage. And what I'm interested in is whether altered dosing intervals might affect response to a drug. This is an example of the sampling schedule for Amgevita. So the black line is a simulation of increasing drug levels in a patient's bloodstream as they have more and more doses. And the different coloured arrows are the different time points at which I'm going to take blood samples. So study recruitment was actually looking pretty good. So my target was 15 patients for each drug. So I got about a third of my target, and then coronavirus hit. So all non-COVID studies were pretty much shut down, and I myself was seconded back to the NHS, and I had to go and work on the front line for 4 months. So nothing's really happened for a bit. However, last week, I was able to reopen my study at Manchester Royal Infirmary, so things are looking up again. Furthermore, because of my work back in the NHS, I've been able to open up some more centres. I've been working at Tameside, so I was able to start a relationship with the research department there, and we're very imminently opening at Tameside. So that's one arm, but I'm also interested in getting the right drug for the patient first time. We know that there are lots of different endotypes of rheumatoid arthritis, so these are distinct kind of subtypes of the population, and it's pretty heterogeneous. For example, we test rheumatoid factor and anti-CCP antibodies in patients and say that they're seropositive or negative, and they have different disease courses. But we also know that these are genetically distinct patient populations. So do different endotypes have different responses? So I'm interested in predicting whether a patient will respond to a particular drug as well. And what I'm particularly interested in my work is finding biomarkers of treatment response. So I am using proteomic studies to do this. Proteins are a good starting point, especially big discovery proteomic studies, because they're easy to measure and they're stable. And another advantage is they capture post-translational modifications. So that's an added advantage over just pure genetic studies. As a clinician, the other thing that's very attractive to me is that there are established proteomic methods in NHS labs, and a lot of lab assays rely on ELISA-based technology. So for my discovery phase, I'm using swath mass spectrometry, and that's data generated by the Stoller Biomarker Discovery Centre. The benefit of swath is, if you look at this spider diagram here, the closer to the apex of each point of the pentagon each of the different colours are, sort of the better it is at that discipline. And if you look at the swath, which is the red, it is consistently the technique that's closest to the outside of the spider diagram. So the study design of my proteomics arm includes serum samples from 159 patients with rheumatoid arthritis at baseline 3 months and 6 months. And these are patients recruited to BRAGS, which is a genetics and genomics study of rheumatoid arthritis patients. I also have 14 healthy controls at baseline. So swath captures everything in the blood at one time, and that creates a permanent record. But then what you need to do is use statistical methods to point the microscope at proteins that you're interested in, the metaphorical microscope. So I'm interested in 624 proteins that I've identified that are associated with RA from previously published studies, and also proteins in the TNF pathway. So step 1 was generating the bespoke protein library. Step 2 is generating protein maps using swath mass spec. And step 3 is analysis to identify proteins of interest. So these 2 steps are completed, and I'm at this point now. So I'm looking to see whether any proteins are predictive of treatment response. It's likely to be more a group of proteins as opposed to a single one. And eventually, what I really want is to see whether this can inform more appropriate prescribing of biologics in patients with RA. So the opportunities here, well, number 1, optimised dosing leads to improved patient care. More cost-effective prescribing, because these are expensive drugs, with the minimisation of adverse events as well. I think it's important to say that even in the patients who have their doses spaced more closely together, you could argue that actually this would get their disease under control more quickly and prevent increased engagement with healthcare, for example, for flares of arthritis. And some people end up being hospitalised because of disability from flares of arthritis. Secondly, I'm interested in enhancing patient stratification in targeted therapy and identifying biomarkers to predict treatment response, either pre-treatment or in the early phase of treatment. So thanks very much.
Brilliant. Thanks very much, Stephanie. That was really interesting. Similar to Mikey's question, can you just kind of explain how you've liaised with public patients during your project and how you'll communicate after with the results, etc.? Thank you.
Sure. So actually, my project has been extremely patient-led, which is, it's been a deeply educational experience as a doctor working in rheumatology who prescribes these drugs all the time without even thinking about it. I've really got to understand all the different facets of it. I think in terms of study design, sampling, booking appointments with patients to attend for sampling, that's all been a rapid learning process in conjunction with patients, the company that provides the medications, hospital pharmacists, and also sort of the hospital teams that prescribe the medications. And I've actually sort of, you see these patients a lot in the first 12 weeks of their treatment. And it's actually, I mean, I probably should, you know, write a blog article or something about it, but actually it's really helped me to understand, you know, the patient's kind of point of view. I guess it's kind of a bit like what Celia was doing, but spaced over 12 weeks as opposed to one interview. And only because, you know, I'm just seeing people so much. How are you doing? How are your joints? Is it working? Some people are very anxious about self-administration. Subcutaneous injections, and I think actually it's been an eye-opener for me. I now am like an expert on all the different injectable devices, which I never knew I would be before, and to the point where actually I now have a patient partner recruited into my study. So again, that's dissemination, I recruited her and then COVID happened, so we haven't got that far yet, but she's basically going to, if there are people who are not sure about the study and are like, you know, want to talk it through and what it's like to participate, she's basically going to promote the study and speak to people who aren't quite sure. So that's like a really good thing that's come out of it as well, because again, it's a new experience for me. It's not something I've ever done. So yeah, I don't know if that answers your question.
No, that's great to hear. Thank you. That's brilliant, and keep it going by the sounds of it. Just a couple of questions from Zahid in the chat function. Have other medical specialties carried out similar studies on biological dosing?
Oh, Carol's helped me.
Oh, right. Oh, bro. Yeah. Another one,
yes.
Recruitment difficulty with the worry of COVID. Perhaps you could address those as well.
Oh, right. So I actually recruited a patient last Friday and he was like totally chill. So it's fine. So we're still prescribing and we're still starting people on biologics. I actually read an article this morning that said they're starting a trial of adalimumab in care home patients in Oxford for COVID, because some sort of large cohort study found that patients on adalimumab actually did better with COVID. So I think I'm definitely going to quote that if anyone's worried about starting. Honestly, I think, so, you know, I've been to like the conferences and I've been to the sort of physician engagement events, and, you know, I've put on the stiff finger gloves. So they've got gloves with like rods in them to simulate what it feels like to have stiff joints. And then they, you know, they give you simple things to do. They say, put on a belt, or, you know, do up your shirt buttons, and you can't do it. You know, you literally can't move your fingers. You can't do it. And I think a lot of people underestimate just how difficult it is to live with rheumatoid arthritis. It's a bit of a silent disease. And I think a lot of patients would rather go on medication that can alleviate these problems and, you know, risk COVID. People are desperate to go on the drugs, so I don't see it being a problem, to be honest.
Okay, brilliant. Yeah, I think Carol's just addressed one of the questions, but yeah, thank you everyone for joining. That's great. Thanks so much to all our speakers, George for chairing as well, and we hope to see you at the next one. Thanks everyone. Bye.